Hello guys, here is Medical Effusion. The answer of the post I've just shared with you is lung fibrosis. One of the restrictive lung diseases that we can see that condition in majority of restrictive diseases, and actually it is a progressive phase of any kind of restrictive diseases that just affect lung parenchyma like pneumonia, some granulomatous diseases like sarcoidosis or TB, some occupational acquired ones like silicosis. If you just pay attention to the chest x-ray I've just shared, you can see a UIP pattern, usual interstitial pneumonia, a diffuse lung, a scarring due to the collagen, deposition into the lung interstitium, and even bronchus walls. And if you just pay attention more, you can see an opacity in your left lower lobe. So the pathogenesis, behind that opacity is, the position of collagen into bronchus walls, and the peribronchial, fibrotic changes causing an air trapping, a pseudo air trapping, because that air trapping condition is characteristic for COPD, obstructive disease. But we can have that condition here too, and it is called the GGO, ground glass opacity. It is not a characteristic hallmark for lung fibrosis, as we can have that condition in other diseases like NSIP, non-specific interstitial pneumonia, and inflammatory phase of HP, hypersensitivity pneumonitis. And basically it is not the as only opacity that we can have in lung fibrosis, as we can see some other ones like reticulonodular opacities, some linear patterns in your chest x-ray, and progressive view in your chest x-ray named honeycomb pattern. Lung fibrosis can cause some other complications too. It can cause right heart failure, that we call it cor pulmonale, organomegalies like hepatosplenomegaly, hepatic congestion, ascites, and peripheral edema. Pulmonary edema, when you're just facing with a patient with pulmonary edema, you got to know that we got to pay attention to the left heart failure. So some conditions like MR, mitral valve regurgitation, can cause left atrial hypertension. At first it can cause an LAE, left atrial enlargement, and then an NAF. So the pressure that your lung vasculature is just facing with rises, and it causes a leakage in your vascular pattern of your lung. So it can cause the accumulation of fluid into your interstitial part of your lung, causing a perihilar pattern that we call it bat's wing sign in your chest x-ray, and some Kerley lines too. In COPD, you got to know that the gold standard diagnostic test for COPD is spirometry, and we are just searching for the ratio of FEV1 to FVC. So the forceful expiratory volume in 1 second decreasing, and then that ratio decreases following that FEV1 decreasing. But in restrictive diseases, FEV1 and FVC are decreasing simultaneously. That ratio is nearly normal. But in chest x-ray we can have some hallmarks for obstructive diseases. We can have some air trapping conditions that showing us some hyperinflation views in your chest x-ray, and some bulla patterns that majority of times they are bilateral, that they are caused by paraseptal emphysema. COPD is mainly divided into two groups, chronic bronchitis and emphysema, that they can have some overlaps in progressive phases, but it is enough for COPD. We can discuss about it later. Pneumothorax can be primary or secondary. When we are talking about pneumothorax, you got to know that majority of times it is because of lung traumas, your chest wall traumas. There is no any difference between sharp or blunt traumas, but in chest X-ray you got to just memorize that your mediastinum will be deviated into the opposite part of your trauma origin. And one of the complications for pneumothorax is pleuritis, inflammation of your pleura. But in some other conditions, and a secondary pneumothorax can be seen in your chest X-ray or your HRCT, high resolution lung CT. It can be caused by lung abscesses or cystic bronchiectasis, conditions that can cause pneumothorax. This is that. So the answer of the post I've just shared with you is lung fibrosis. You can see a UIB pattern in your chest X-ray because it is a progressive restrictive lung disease. That UIB pattern is due to the collagen deposition into your interstitial lung tissue and an opacity that we call a GGO in our left lower lobe because of that fibroblastic activity and collagen deposition peribronchial or into your bronchial valves.